Kindly request our chairpersons to introduce our speaker.
There's the burning problem, ADHD. So its specialty is not only psychiatry and neurotic problems. Even the neurologist and psychiatrist both should participate in the treatment. So it is very difficult to diagnose. Of course, only clinically, particular diagnosis will be there. But the challenge to the psychiatrist is we are unable to show sudden improvement, immediate improvement. They will think they like a depression, schizophrenia, even the major disorders. He is talking. So I request Dr. Sreeraj VS to continue the topic.
Sreeraj is MBBS, DPM, DLB Psychiatry and PDF Clinical Neurosciences. Current designation is Associate Professor of Psychiatry, NIMHANS, Bangalore. And awards are Icons of Young Research Award and WSPB Young Research Award, ASHA Award, etc. And editor assistant in Asian Journal of Psychiatry and Archives of Clinical Psychiatry. So area of interest are brain stimulation and transcranial electric stimulation is the main one. Neurology of psychiatry disorders and psychotropics. So I welcome sir to continue the topic, and it's also a new domain for me. I'm very much interested to learn all these things. Thank you so much.
We all know about the ADHD, and ADHD is not a very simple disorder. So there are specifically some of the core symptoms which are there. It might be inattention, hyperkinetic, impulsive behaviors. There could be impairments in the working memory, response inhibition, but also there are many other symptom profile which may not be really the core, but they are really the worrisome consequences of some of the core aspects of the ADHD. That includes conduct disorder, substance abuse, which stems from cognitive inflexibility, emotional dysregulation, these kind of many other dysexecutive functions. So, if we try to understand any psychiatric disorder for that matter, and ADHD also in particular, the problems that we understand at this stage is not just with respect to the neurochemicals, but it's an amalgamation of multiple ways in which we can understand the brain. One, now we are trying to understand it through the connectivity between different brain regions. Two, the oscillations. The brain regions are connected to each other functionally, and they talk with each other primarily through the oscillatory signals. And also, yes, the neurochemicals. And the neurochemicals, we have been concentrating mostly on the subcortical regions, but nowadays the more emphasis is on the excitatory and inhibitory system, and then the imbalance that happens, and that is where most of the clinical symptoms, cognitive deficits, which are something which is seen across some of the major psychiatric disorders. So this seems to be the core of any psychiatric disorder. And the specificities changes with the kind of manifestation it comes up with, the kind of symptoms that we get. If you look at the neurocircuitry of ADHD, so there are multiple regions which have been attributed. The problems would be in the prefrontal region, as we all definitely remember and understand, but it just does not stay there. The problem is also seen in activities in the SMA, that is the supplementary motor area. It's also seen with the parietal region. The problems are not just there, it's also in the nucleus accumbens, amygdala, thalamus, and the cerebellum. And the circuits which are there within each other can be the one which is underlying each of the symptom domains that we see. It's like the frontocerebellar network are the ones which are important for predicting what is happening. The cerebellum is the one which predicts the timing, the temporality of our functioning, and when the temporality gets disturbed, that is where all the disorganization starts happening. The reward circuit, including the nucleus accumbens, is something which is very important in ADHD as well, and the lack of motivation, which leads to lack of perseverance, and thereby amounting to the inattention, could also be the, one of the important regions. The frontostriatal networks are the ones which are implicated with the hyperkinetic symptoms. The executive function network is also involved, including the dorsolateral prefrontal cortex in the parietal regions, which leads to disexecution that we will be seeing in these patients. And definitely the inattention part, again, it is related to the executive functions but not just restricted to that. So how we can try to solve this? So as of now, we have been trying to use medicines, and medicines we do have excellent amount of medicines even for ADHD, but there are issues with medications. One of the issues is that treatment will not really last longer. Unlike other treatment, you might have to continue, and you will be able to see that time to time response of the dynamic changes that will be happening with treatment, and if the treatment is stopped, the again symptoms will come back. So it is not sustaining many times, and the adherence is also an issue, and many times the adverse effects, because though we target something, we will not be able to target specifically with the medications what we give. It goes systematically, and then it leads to different other side effects. So that is where there is an emergence of interventional psychiatry. It's a subspecialty of psychiatry now, which is emerging, which uses different technologies in neuroscience, including things like EEG, MRI, FNRS, as well as the neuromodulation techniques like TMS, tDCS, and thereby help us in advancing the knowledge of psychiatry and advancing the therapeutics in psychiatry. To that extent, when we look at the brain stimulation techniques, so we can the brain stimulation techniques are, we can stimulate the brain, even like when I'm talking to you, it's also stimulating, it's also altering how our brain functions, how our brain works, and it's inducing the plasticity. But what we concentrate when we are talking about the NIPS, the brain stimulation, is the physical methods in which we can alter the brain, and we can use multiple physical methods. One, it could be electricity. Second, it is the magnetic current, which again will get converted into electric field in the brain, and then it will be altering the electric potentials in the brain. Third, we can also use sound, and we can also use light, which is called photobiomodulation. So these are some of the emerging techniques which are there. But for today's discussion, we are going to restrict to the electricity, not go beyond the electricity, because in the area would go much higher. One of the most well-known and well-used, and I would say one of the most efficacious treatment till date in psychiatry has been the ECT. We will not be using that because, again, for the ADHD, that's not really the treatment that has been tried or used. So we will be restricting to the weaker intensity stimulations and how do they work and how we use them. So when it comes to neuromodulation, so it's always a challenge. It's always a compromise between how much invasive you can or non-invasive you can be and how much spatial you can be resolute. So if you want to stimulate very precise area, precise brain region, then you might have to go deeper. You have to invade, you have to put some electrodes inside the brain, which again will lead to different complications, and acceptability may not be really good, and the risk benefit might not be really great. But the kind of stimulations that we are trying, like the TES, they have very less spatial resolution, so they do stimulate little larger brain areas. Nevertheless, it will be much lesser than what you see with, say, the ECT or the MST, where you are inducing seizure and you will be stimulating the whole of the brain. So here we will not be stimulating the whole of the brain, but the specific brain regions, and for that we will be using these specific electrical circuits. But again, there are advancements in this field, and you might be able to see there are high definition TES, or there is an advancement towards transcranial interference stimulation, which can go much more focal, and we might be even able to go to the depth. But again, these are still emerging. I again does not want to wish to discuss about these newer emerging aspects, so that I don't want to confuse you. But we will try to restrict to the conventional ones where we will be stimulating little larger area, but still it will be focal enough for us to target and get clinical benefits out of it. So again, going back to the neural circuits, what we were discussing there. So there are different neural circuits, different neural regions, because these are the regions we need to understand, because these are the regions which we will be targeting. And when we target any brain region, that will be based on the neural circuits that we understand with respect to the symptoms that the individual would be having. And it is not generally the syndrome that we will be always be targeting, but it will be specific symptom domains that we may be targeting in neuromodulation techniques, may it be tDCS or RTMS. So understanding the neurobiology and thereby understanding where we want to target becomes more important. So The issue with tDCS or even RTMS is we will be able to stimulate the superficial regions. As was mentioned, we might not be able to go deeper. The depth might not be really possible at this stage, though there are advancements that are happening. So some of the superficial regions which are implicated and important in ADHD are definitely the dorsolateral prefrontal cortex, which will be important in both controlling the attention. At the same time, the ventromedial prefrontal cortex, which is important for controlling the emotions, as well as the orbitofrontal cortex, which comes up, which is important in controlling the behaviors, the impulsive behaviors. When you are seeing more of the impulsiveness, you might want to target the orbitofrontal cortex. When you are seeing more of emotional disturbance that are happening, you might want to target the ventromedial prefrontal cortex. And when you are seeing more of an inattention or more of disexecution, we might be wanting to target the dorsolateral prefrontal cortex. So this is the basic biology, and the biology does not stand there. It is based on the circuits, so we will be targeting the circuits and the isolated regions. And when we stimulate with any of the brain stimulation techniques, we will be stimulating the whole network rather than just stimulating the specific regions. So each of these circuits, each of those regions have its own importance in different manifestations. We don't see all patients with ADHD to be similar. The manifestations are different, and the core problems are also different. And those problems can be boiled down to the problems which are there in each of these different circuits that are there. So the frontostriatal circuit, as we were discussing, could be important with the hyperkinetic problems rather than just the exclusion. So when we have to target, so now we understand that there are different regions. So when we have to target it, we generally use the 10-20 AD system. That is the easiest way in which we can target the brain, and we can see, because in the skull, I hope most of you are aware of the 10-20 AD system. So this is the system which we use when we are recording the electrodes, EEG. We place the electrodes based on this system, and based on the same system, we now will be giving the electric current or the magnetic field, so that we will be able to stimulate the specific brain region there. So here, the anterior part, that is the FP1, which coincides with the orbitofrontal cortex. The F3 is the one which coincides with the DLPFC. The center point between the FZ and CZ is where you generally get the SMA, that is the subcutaneous motor area, and temporoparietal junction, which is generally targeted for auditory hallucinations, comes in between the T3 and T3. So this is the region that we target. So this is in general that we try to target different regions, and we use different systems. Whatever the systems that you are going to use, whatever the neuromodulation techniques that you are going to use, this is the basic with which we will be identifying the region and we will be trying to target the region. So coming to the most common transcranial electrical stimulation that we use, that is the transcranial direct current stimulation. This is one of the weak intensity neuromodulation technique, and here we will be using the stimulation with an intensity of as much low as 2 milliamperes, generally within the range of 1 to 4 milliamperes, because this is found to be the safer region where we will be able to make a difference in the excitatory potential of the brain. So any conventional tDCS, as we all, if you can go back to our 10th, 12th period, for any electrical circuit, there should be an anode, there should be a cathode, right? So the electrons moves from cathode to anode, and current flows from anode to cathode. So here the electron is what is being demonstrated. So the movement is happening with respect to the electrons. Now, anode is the one which is the positive field, and cathode is the one which will be negative field. The basics of tDCS is pretty simple. Wherever there is an anode, you will be able to increase the resting membrane potential of those regions, right? So you will be able to make that region more excitable. Now, if you want to induce a seizure, if you want to induce TMS activity, a pulse, or if you want to get any signal which is not really coming up better, now if you place the anode over there, you will be able to get the excitability with even a smaller amount of stimuli. So that is the basics, right? So wherever you are placing the anode, the region, the brain region which is just underneath that, will get activated and it will go to the excitatory. That is, the resting membrane threshold itself shifts. And wherever there is a cathode, it is the opposite. Right? Here there will be reduction in the excitability. Rather than inhibition, I would say it is the reduction in the excitability, in the sense that there will be a downward shift of resting membrane potential. So you would require higher amount of pulse to get an action potential. So how easy or difficult you will be able to induce an action potential in a neuron will be based on the anode or cathode. And if you place an anode and you stimulate the brain region for say at least 9 minutes and maybe up to 30-40 minutes, you will be able to bring about the change so that the excitability will be increased. That means the threshold will be reduced. So you will be able to stimulate that brain region very easily. Wherever there is a cathode, it is the opposite. The excitability will be reduced, the threshold will be increased. So you need more stimulus to bring in the same amount of response from the neurons. Right? We are clear about this point because this is the basic point. If you understood this point, most of the understanding about the tDCS from here on will be much more simple. Right? So, but there are multiple features which comes in, and those are the features which becomes more important. What happens is you are giving a very low intensity of electrical current, as I'm telling you. If you keep it very low, and in some individuals where there is a the brain there is an atrophy which is there, so you might not be able to really reach the underlying cortical region which you are targeting. Okay, so the amount of electrical intensity becomes quite important, and the placement becomes very important. How you are placing, how exactly you are placing becomes important. That will help us in getting the electrical field appropriately in that appropriate region. Though electrical field would be there everywhere, but that might not be able to bring about the physiological change that we are eliciting, because what we are doing is a very small change that we are trying to bring in when we are giving it for a long period of time, and we are doing it repeatedly so that the change gets potentiated and we will be able to bring in the plasticity. That is, we will be trying to look at the long-term potentiation or long-term depression that will be happening in the glutamatergic neurons. So the minimum time period required for any physiological effect to happen will be around 9 minutes. Okay, so 9 to 20 minutes or 30 minutes is where the most of the effects happens. So we might think, okay, let us keep continuing. So more the better. That is not the case. That's not the case with brain. Brain always has its own protective mechanism. So it is also seen that if you stimulate more than 40 minutes, beyond 40 minutes, the effects changes, the polarity effects changes, because then the homeostatic capacity sets in. The brain starts responding or defending itself from getting altered too much. And then wherever you are keeping the anode, there, rather than excitability increasing, it starts reducing. And wherever there is a cathode, rather than it getting reduced, it starts. So it becomes more and more unpredictable. So we will generally, if you see any papers or any treatments, the protocol will generally be for 20 to 30 minutes. We will not go up to 40 minutes. We will not keep less than around 10 minutes also, so that we will be in a safe range between 20 to 30 minutes. And when we are giving the stimulus, we are giving it only small amplitude of 2 milliamperes, but we don't give 2 milliamperes if say this is the 2 milliamperes, this is not directly what we will be starting. So the treatment is generally very safe, very well tolerated. There will be some amount of itching or tingling sensation that you might see. Very rarely, if you have not done properly, then only there will be burning sensation, burning can happen, and that too will be small amount of blephs or something like that. But if you do the procedure properly, so the treatment is pretty safe, but it has to be done properly. That clause should always be kept. So, but at the same time, you won't directly start it to 2 milliampere. We use a period that is called fade in, a period called fade out. That is the time when we gradually increase it. So we usually take at least 20 to 30 seconds to start from 0 and to reach 2 milliamperes. So we will be starting with 100 microamperes, 200 microamperes, 300 microamperes, and each second we keep on increasing and go towards the reaching the 2 milliamperes. That is the 2000 microamperes. So the same thing we will be doing when we are fading out. If we see electrodes on the frontal region and all, you might be able to see flashes of light, like phosphenes. It's like a kind of flash comes out and goes off. They are not harmful, but nevertheless they will be discomforting. So it's always better to reduce the discomfort and so keep a fade in and fade out period. And as I was mentioning, it is not single session which has the effect. That is good for neuroscience studies. Generally, in the healthy humans, whenever we do some experiments to understand the activities of the brain and look at potential effects of the tDCS or the effects of the regions and how the region is implicated. There we use only single session. But when we use it in treatment purposes, so we have to give it for multiple sessions. Okay? And how often you give also becomes important, and how many times you are giving is also becomes important. Okay? So here, generally we go for 1 to 2 sessions per day. So there are studies now, we have also been trying to go for up to 5 to 10 sessions. We really don't know where is the safe limit, where it actually again, the homeostatic acetamide again setting, so those are many unanswered questions we still have. But for regular clinical purposes, it is 1 or 2 sessions. At least in disorders like schizophrenia, we have good evidence that 2 is better than 1. Wherever the ascites have done using only single sessions, they have been most negative, and wherever they have done at least 2 sessions in a single day and given it for 5 days, we have been able to see that it can reduce the hallucinations. So these are some of the important points. So what is the intensity of stimulus you are giving, what is the duration that you are giving, how many times you are giving and how many days you are giving, and how often you are giving, what is the time gap that you are giving between the 2 sessions. The other important factor is also about the electrode size. So generally we use an electrode size of around 25 to 35 centimeters square. So it depends on again the brain region. So sometimes particularly in conditions like ADHD, if you are going to treat children, so you might have to, because the electrodes will be too much on the head, and it might be too big for the head size. And the electrodes should be placed wide apart. If they are too nearer to each other, then the electric current will shunt from the scalp itself. They will directly go from the scalp, it will never reach the brain. Again, it might not be useful. So we need to be keeping it at least some 5 centimeter or 7 centimeter, or we can say 3 finger distance. The 3 finger distance should be there between any 2 nearest edge of the 2 electrodes, right? So that will make sure. So in that sense, sometimes you might have to go for reducing the electrode size, and the smaller the electrode size, more density of the electric current that will be there in that electrode. So in that sense, the tolerability might again be a little challenging, so we might have to reduce sometimes the electric current. So these are some of the aspects that we need to understand when we are choosing the electrode size as well as the parameters. But understanding these parameters and choosing the parameters is something which is the skill which you have to develop before, rather than skill, it is the theoretical knowledge that we need to have before we move forward and use it for the theoretical purposes. So, why tDCS now? So, you all understand that actually the electric current was used somewhere in 400 BC, so it was not really a recent one. But nevertheless, with microcontrollers, we are now being able to precisely deliver the exact amount of electric current that you want to give. And because of these advances in the technology, and our ability to understand what is happening in the brain with the neuroscience tools that we have, like the fMRI, the EEG and all. So we are able to understand that yes, this low intensity of electric field current or the field that we are generating is able to make physiological effects, and that is where we are advancing with this field in last 20 years or so. What's the advantage of tDCS and TES compared to, say, other aspects? So one, it is cheaper, it is very cost effective, you might be able to get it in a few thousands to few lakhs, unlike any other devices which will definitely cost lakhs and sometimes even crosses a crore rupees. And definitely you don't need to have anesthesia to give any of these stimulations, both RTMS or tDCS. Both of these are non-invasive. Other things you might have to invade at least for giving anesthesia. And tDCS is also one of the biggest advantages. It is portable. Though this advantage we have not yet utilized to the full extent because we are still in the phase where we are still looking at hospital-based treatments. But nevertheless, that is where we are moving forward, and that is what we will be discussing in future also in this presentation. So, coming back to focusing on ADHD. Now we discussed about multiple circuits, so and all those circuits are implicated in ADHD. So the same thing will get reflected in the studies that we have, and this is the problem with the literature as of now. There are studies; it is not the studies are not there, but each study they are not comparable. Each have targeted different brain regions. One has targeted the dorsolateral prefrontal cortex, the other has, one has targeted the left dorsolateral prefrontal cortex, the other right dorsolateral prefrontal cortex, one has targeted the orbitofrontal cortex, the other has targeted the ventromedial prefrontal cortex. So each has its own benefits, but when we are targeting and in heterogeneous conditions like ADHD, where one might be having more inattention, one might be having more hyperkinetic. So we really don't know the evidence. That's the reason we have not been able to generate the amount of evidence that we expect. But nevertheless, that is the work in progress, and hopefully we will be having better answers about its real utility in coming years. And as I was mentioning, so this is just a similar picture from the recent systematic analysis, systematic review and a meta-analysis, where you can see that the target. So based on the target where you are stimulating, so sometimes in the F3, sometimes in the F4, you will be able to see different brain regions which are getting stimulated, and thereby the effects are also altering. So to be precise and simplify it, so if there is more of inattention, probably it's the left DLPOC which is better target. If there is impulsivity, the right IFG and probably the PSMA could be the target. If there is inhibitory control disturbances which are more, then again interior frontal guidance or DLPOC would be better. Working memory, again bilateral DLPOC might be something which could be better. If there is a cognitive inflexibility that is a major issue, then left DLPOC and the frontoparietal circuits could be something which could be the target. And if there is a lot of emotional dysregulation you are seeing, so probably the ventromedial prefrontal cortex is something that we might want to target. Now coming to the real challenge. As with any other neuromodulation techniques that we have, we target, we treat the patients for a few days, but after that, the question is how long the treatment, the response persists. With medications, we can prescribe, they can go back, take it home and keep taking it, but that may not really be the case most of the times, and not all the patients will sustain the improvement. We have seen the sustainment of improvement to be anywhere between 3 months to many years. So we really don't know how long it sustains, and it is as similar to ECT we will be having experience with ECT. So there might be need for patients who might have to receive the booster sessions, or we might have to continue them with a maintenance tDCS, and all these are more challenging when the patient has to come every time to the hospital to take this treatment. And again, the portability is something which is helping us in taking these devices to home and administer the tDCS at home, what we call as home-based TES treatments. And it has been tried in multiple conditions, and there is one study in ADHD I could see, but apart from that one study, it's primarily in depression, and there are a few studies in schizophrenia, but in neurodevelopmental disorders as such, there is only one study where they have tried using it in ADHD. And this is some of our experiences. So we have developed a standard operating procedures with the kind of devices that we have. We have devices which are more flexible, but for today we'll be demonstrating. We'll have a brief demonstration on the device that we have here. And this device is kind of made for home-based administration, where the administration is much more simpler, but it is inflexible at the same time. So there will be pros and cons of each of them. In the sense, when I was discussing about multiple targets that we can choose when we are using the tDCS, but here we may be limited with the targets. Nevertheless, the ease of administration will be easier, and probably the home-based would be much better. But nevertheless, if you have a regular tDCS, conventional tDCS, then we need to really work towards increasing the acceptability and increasing the rigorosity of the administration. So we have prepared an SOP and we have administered it in few of the patients, and the patients who are receiving it for a few many years, sorry, few many months now. And we do it in multiple phases. One, we have to choose the patient properly, we have to choose the device properly, so that the patients or when the caregivers will be administering the sessions, they will be able to understand the needs behind these stimulations. And initially we go for an observation learning, where the caregivers and the patient see what is happening, and then they do it on the mannequin, and then they administer it on the patients under supervision, and finally after assessment for the competency, we will be taking them for the home-based treatment. So apart from the home-based, apart from the tDCS, there are other waveforms which are also there. So I'll just give a brief introduction. So direct current is single polarity from cathode to anode, but you can go with other stimulation techniques like alternating current. You can give randomized current, or you can give in the burst current, how we give in the how we give it in the ECT. So alternate current has been used in ADHD, but is very used in only 1 or 2 studies, where again the whole focus will be on enhancing on entraining the neural oscillations which are there in the brain, the alpha, beta, theta waves what we have, and we are aware of the importance of the beta and theta waves, alpha and beta waves in attentional aspects and how they are important. So if we can increase it, enhance it using the tDCS in the specific brain regions, that will enhance the attention abilities and the executive functions. So that is the whole idea behind the tDCS. But also there are studies which have used TRNS, the random noise. So the whole idea is here about giving an optimal level of the noise. So rather than giving a direct current or the alternating current, give the noise, and so that a system threshold will be crossed by this noise, and you will be able to get only the signals rather than just the noise. So you should not be giving very high noise, or you should not be giving a weak noise. So optimal level of noise will enhance the signal. And TRNS is something which is used in ADHD children. There are 2-3 RCTs which have found it to be having much potential. The two, they have been giving it when the individual is going through or doing a task, and with that they have showed that TRNS might be of help. Rather than just the top-down approaches, now there is an emerging evidences towards the bottom-up approach, where you can stimulate the cranial nerves, which will target your locus coeruleus, the ventrotegmental area, which are the nuclei which sends the dopamine or norepinephrine, which we target as medicines also for ADHD. And these can be targeted through the cranial nerves. And if we stimulate these cranial nerves, we might be able to bring in the changes. And it has been shown, and we have good amount of evidence to show that the vagus nerve stimulation, we already know vagus nerve stimulation is one of the FDA approved when you invade it, but now you can do it without invasion by targeting the vagal nerves which are there on the ears or on the neck. It's called transcranial, transauricular or transcervical vagus nerve stimulation. And with that also you will be able to bring about the changes, primarily enhance the attention. But what is surprising, probably most of you might not be knowing, is there is one form of treatment that is not the vagus nerve stimulation but the trigeminal nerve stimulation, and this is something which has been FDA approved for ADHD. Nevertheless, there is only 1 or 2 studies which have used, there are 2 or 3 studies which have been published with tDCS and with which the FDA approval was obtained, and here they use similar electrodes what we use in TES. Rather than giving for any nerve stimulation, rather than giving a direct current or alternating current, we generally use the pulsed current, because pulsed currents are the ones which will be able to modulate the external nerves, the neurons which are there on the superficial aspects. So using the tDCS and giving it for 30 seconds and off, switching it off for 30 seconds, and this they have been giving it, the protocol they use is they give it overnight for 6 to 8 hours in the children, they have done it in even the adolescents, adolescents and the adult ADHD. And the RCT has found that eTVNS, which is given for at least 2 weeks, has had an effect which persisted for a month and longer. This is the study which shows that there is a persistent improvement that happened, and the improvement even increased even after stopping the treatment, which did not happen in the sham ECT, sham PMS. So, not just that, they were able to show that even it altered the PET, in the PET brain, it was able to alter how the behavior that are happening in some of the core regions of, that is the prefrontal cortical regions as well as the temporal regions, which we were discussing earlier. So they were able to say that the activity of those regions would also be altered with the TMS. So this is in brief about different studies which have happened. Most studies are with tDCS because of its safe ease of use. There are some studies which are in TMS, and rarely with TRNS, tDCS, tDCS and TNS, but TNS is something which has been FDA approved. And again, giving a very brief about TMS and tDCS. TMS seems to have a better effect, stronger improvement, but shorter lasting, and scalability is something which is problematic. The advantage with tDCS is it has scalability, it can be used for a longer period of time, but the problem is it has a very small effect size and might not be useful primarily it is being found to be helpful with working memory and executive function, and to some extent the hyperactivity and impulsivity, but not really much with inattention component of the ADHD. Right, so with this I would like to stop the presentation, and we have a brief demonstration. We have a device from the Marbles book here. So, this is the, I hope that generally the devices that we will be having, as you had seen in the slides, so there will be just 2 electrodes that will be there. The electrodes are inside this here. Okay. So these are the electrodes which are there, you might be able to see. So generally the electrodes will be just connected to a wire, but here to make it more user friendly, they have designed it such that you can just put it on your head and you can still stimulate. The problem is you will not be able to flexibly use it. It has some limitations, restrictions in the target that you will be having. Nevertheless, it is primarily designed for stimulating the dorsolateral prefrontal cortex. You might not be able to stimulate other brain regions. And there are 2 electrodes that you can see here. Okay, so when you put it on the head, it gets stretched. So when it stretches, at least there should be 3 finger distance that should be maintained. That is what we need to ensure. And when one of the important components to improve the tolerability or reduce the side effects is you won't put the electrode directly onto the skull. Okay, this is something, please remember, don't put the electrodes directly on the skull, because there will be on the skull or on the head hair whenever you are putting, there will be a lot of unevenness even because of the hair. Okay, so the electric field will not be equally formed. Then it will lead to seepage of electricity into one specific region, and that can lead to burns or other problems. Right? So to reduce that, what we do is we use sponges like this, and these sponges will be wetted. So we use usually the saline. Okay, rather than normal saline, it would be better to go for a little diluted saline, but primarily saline, because saline water is not conductible, so saline is conductible. And when you use the saline, it kind of spreads across, so it won't get restricted to one single region. So what we'll be doing is we'll be wetting the saline, but at the same time when you put the saline, you should ensure that it should not be too wet so that it starts dripping, but it should not be too dry that it will not really conduct. Okay. So the optimal amount of saline with which even if you press, you will not be able to get the water seeping down. Right? So when it presses there, it's not seeping down. So that is what we need to ensure. So this is one important aspect that we need to be aware of. And then we will not get into again, because of the shortage of time, we will not get into how to identify the F3, how to identify the F4, but those are some things which definitely you might will have to understand and get some hands-on training before you start it. We discussed briefly about the 1020 system. There are a few other systems which can make your life easy. There is a free open source software called Beam F3 which can be used, where you have to put measure only 2 or 3 coordinates and you will be able to get to the F3 easily. And it has been validated for its reliability with respect to the TMS and tDCS. So you can use such tools and you can identify the target, and generally you will get PLPUC somewhere here on the left and somewhere on the right here, and this is the region that you might want to target. So when you are placing the electrode, so once you wet it, and then you will be placing it, so you will be placing it something like this, so that it will be targeting your brain here. Right? This device also has capability of EEG, so simultaneously it will also record EEG, but recording EEG during the stimulation will just send you the noise, but I think it will be more useful for some studies where you will be able to look at the EEG before and after, and there may be some predictable potential of that. Nevertheless, so this is the basic simple setup of tDCS. So based on the clinical needs, we might want to go for tDCS or even enhanced aspects. Yeah, I think I will stop my talk here, and we can take some questions. Yeah, maybe we can.
Does anyone want to volunteer for a demonstration session? Please come. those sponges, and we have to wet them with saline. We'll just do that. So, would you like to just catch that? So it's a normal saline. Essentially, as sir mentioned, the amount of saline that we have to put is directly proportional to the amount of hair. In case there is very thick hair, then you will have to want to part it a little so that the saline is actually stimulation. Then a normal amount of saline is enough. At the end of the day, what we want to ensure is that the patient is feeling wetness at the site of stimulation, and through this software, technically the software will also tell you that is the stimulation impedance high or is the stimulation impedance perfect. So in case the stimulation impedance is high, that means that the area is not wet enough and the current is not flowing properly. So the advantage of this software is that it will tell you that, so you don't have to guess. If the flow of current is not proper and if the impedance is very high, you will get to know.
Maybe to just add in one component that's quite important when we are administering tDCS. What we are setting is we are stabilizing the current, the intensity of the tDCS. That is, we are setting it as 1 milliampere or 2 milliampere. But the impedance is nothing but the resistance. Resistance, we don't call resistance because resistance is what is a very simplest aspect. The brain does not work just as a resistor, but it also has a capacitor, so there are multiple aspects to it. So, and it is also dynamic, so that's why we call it as impedance. The resistance offered by the brain keeps on changing, right? And based on the resistance, the voltage which is sent also alters. And if more voltage gets in, that is the one which will be leading to more side effects. So we have to monitor the impedance. So generally we keep an impedance somewhere less than 10 kilo ohms. If it is crossing beyond that, then the devices will be made in such a way that it won't even give the current. Okay? And even within that, we want to keep it at the lowest possible way. And some of the things which can increase the impedance, as she was mentioning, is the hair. So you might have to really part the hair and expose the scalp. We will be able to make sure that the current flows properly. There are other problems that could be happening, like you have put less saline. That's the reason why current is actually not reaching and the circuit is not getting closed. So you might want to increase the saline. In some patients, in patients with psychiatric conditions, they might not have cleaned their hair properly, so there could be a lot of dirt and dust that could be there. A lot of times there could be lice that will be there. And if those are the things which are coming in the circuit, that again can lead to unevenness in the electric flow, and that can lead to burns. So we need to be extra careful in such patients. Have the hair cleaned properly, shampoo it properly, see that there are no moving lices or a lot of lice which is there, and then administer. So these are some of the safety aspects which we need to ensure before we plan.
So Dr. Vashi is just wearing the device. So essentially when you're wearing the device, Sir had mentioned that according to the 1020 EG system and through other modalities, you'll have to identify where the F3 and F4 locations are, and then you have to wear it, whoever is administering the treatment. By virtue of this device, when you wear it properly, it automatically goes and sits on the F3 and F4. So that makes it easier for anybody to start using the device, and especially if you're sending it home, then you don't have to worry that the patient is not putting the F3 and F4 location properly. Essentially, if they wear the device properly, it will go and sit on the F3 and F4 location. So what we have to ensure is that the bottom band is 1 finger width above the eyebrows. So here, the bottom band is exactly on the eyebrows, so we raise it up a little, 1 finger width above the eyebrows. Second thing we have to ensure is that the device is sitting right above the ear lobes, and the black part behind is behind the ear. So some people also might wear it like this. That is not right. This is right, where it's going and sitting above the earlobes directly. So once the placement is right, it's very simple. We can just start the session. Here you can see that the device is switched on. So if you can move your head to the left, So the yellow light is blinking. That means that the device is on and ready to pair. So this device works using Bluetooth. It connects to a mobile application. Specifically in this case, it connects to a tablet. So what we do is that we set a treatment protocol for the patient. Let's say we are setting 20 sessions twice a day with a minimum gap of 3 hours and 20 minutes. Once we have set it, all the patient has to do is that they have to log in with their patient ID and their first name, and they have to start and stop stimulation. So all that needs to be done is log in and stop stimulation. Before sir does that, I'll show you how to add patient information very quickly. So let's say first name is Dr. Varsi. Okay, fine. We'll skip the patient adding details. It's very easy. All you have to do is add whatever is required here: handedness, contact number, gender, age, first name. You can also add diagnosis, current medical treatment, etc. Coming to, let's say we have a patient called Nitin, and we just set the treatment protocol. So here we've set a treatment protocol for 20 sessions over a period of 10 days. Now in case I want to add or modify something, I can simply just click on the session. I can edit the session. I can change the tDCS current from anywhere between 0.5 milliamperes to 2 milliamperes. On special request, we can also increase 2 milliamperes to up to 5 milliamperes. Yes.
So yeah, so this is something which is important, the setting of the protocol and what you really want to look at as we were discussing. So the current generally that we use is 2 milliamperes, which can range anywhere from 0.5 to 3 or 4 milliamperes. So 2 is found to be the safest of the options. But now there are studies which are showing that if you increase it to 3 or 4, maybe there is a better efficacy, but the importance also could be there, so we need to be really looking at it. The second, as we discussed again, is about the duration of the treatment, how long we have to give. So you will again have some options over there, like 20 minutes, 30 minutes. So just show.
Yeah.
So you can, so even it can be, some of the devices will give you an option to make it 1 minute, 2 minute, 3 minute like that also, but here we have some set. So anyway, this is generally would be good enough. So having somewhere between 20 to 30 minutes is what clinically generally is recommended. And it's also about the total intensity of the,
yeah. So when we start the stimulation session, then it ramps up over a period of 30 seconds, and then it ramps down. Whenever the stimulation stops, it ramps down over a period of 30 seconds. There is no sudden start or sudden stop. We can also see session insights. For example, I go to a patient, like let's do one session, and based on that I'll show you the session insights.
take the simulation.
Yeah, okay. So already this is in progress, this session. We'll just start the session. So the ID is 192716. 92716. And the name is Nitin, Nithin.
Because of the lack of time, probably we'll stop it here anyway. It's just that we'll have a stimulation, so generally it will be tolerable, and even the patients will be sitting as usual, and even there are options, like even they have the options that they can do some cognitive tasks. So again, the pros and cons of what state of the mind that you want to stimulate, again depends on the evidences which are there. In some certain cases, it might be contradictory. If you give the task, it might reduce the plasticity, sometimes it might be enhancing the plasticity. So we need to be aware of all these smaller nitty-gritties and how to plan the sessions. But nevertheless, the good thing is they will be able to do any of the tasks, and you might be able to bring the circuits which are targeting to the active state, and then you can add on the treatment, and then you can enhance the further improvement to be happening in those sessions. But again, we need to be worried about the homogeneous plasticity and need to see what is best for the individual based on the whatever the knowledge that we have.
There are also some session insights that you can see. Whenever a session is completed, it comes in green color. So this is the session schedule. This is the session insights right next to it. So let's say Divya is a patient that completed the session on 7th August 25, day 3. I click on the session. So this is all the data that you can see. You can see the treatment test scores. You can see the intensity, the protocol duration. You can see the session stages. So if the EG was done, you can see the graph. If the post-EEG was done, you can see the graph. If the tDCS is done, we can see that graph. I'll show you the tDCS graph, how it comes. So you can see that the expected current is 1.5. The red line is expected current. The black is the actual current. No other device sort of gives the kind of graph. There's a lot of error when it comes to hardware devices. So since this particular device gives this graph so that you can compare that what is the current that you've set and what is the current that has been delivered. As sir was mentioning, over a period of 30 seconds there is a ramp up, and then last 30 seconds there is a ramp down. And so in case there is any cognitive task, as I was mentioning, the patient has done, you can see the output of the cognitive task also. And you can add any session details in this particular session information. And there's also reports that can be generated after every 10 sessions. If you want to see a detailed demo, please, you can catch us later. Thank you so much.
Most of the antipsychotics are seizure-prone. So what kind of precaution we have to take?
Okay, that's a great question. The risk of seizures with tDCS is pretty minimal. There are only 2 or 3 cases where there are also many other risk factors which are there which lead to seizures than actually tDCS leading to seizures. Unlike PMS, where the risk of seizures is much higher. And that other issue with tDCS is it is also used to reduce the seizures in epilepsy. Like if you use the cathode on the region where you are keeping the electrode and you are reducing the excitability of those neurons, then you will be able to reduce the epileptic attacks as well. So it is being used even in epilepsy also. Now coming to the medications, so the risk is very minimal, so we need not really worry about seizure as a risk with any of the psychotropic medication. The problem can happen with the plasticity, and the dopaminergic system, the serotonin system, they are the ones which enhances the plasticity. And even with some of our observations, what we have seen is if an individual is on strong D2 antagonist, if the individuals are on things like haloperidol, risperidol, the response was not as good as those patients who are on, say, olanzapine or clozapine. So similarly, the individuals who are on fluoxetine might have a better response. The problem, if a person is smoker and had taken nicotine in last few hours, that can reduce the response. So these are some of the early indicators towards there is an interaction between the tDCS and the medications, but they are not going to cause any major side effects. So that is really not the worry, but it can definitely impact the response, and that is where we need to adjust the doses or plan the system.
Outcome of the illness, only using tDCS and medication and both combined management. So which one is the preferable?
As of now, the evidences, whatever we have, is tDCS as an add-on treatment. There are few cases where we knew that the patient had responded earlier, so then we had gone to only tDCS and we have seen responses happening in such individuals. But otherwise, it is something similar to ECT, how you plan ECT. You don't just rely on ECT, but you use it for augmenting early response creation and sometimes in the resistance to get a better improvement, but nevertheless, we will also keep them on medications. With respect to ADHD, yes, the data is not clear. Again, the combination, so there have been studies in depression where they combined tDCS with sertraline, they gave only sertraline and they gave only tDCS. The combination of sertraline and tDCS was better than only tDCS, but it was also similar to only sertraline also. So that was the one of the negative findings we could say towards tDCS, but nevertheless there were many factors why that happened in that study. Nevertheless, what we can definitely see is with medications, at least in depression, with serotonergic drugs, the combination is better. With others, we really don't have, but like in schizophrenia where we use regularly, we do not use it as an add-on, as a monotherapy. Only 2-3 cases where we have done it and we have reported it, but otherwise it is always used as an add-on treatment, adjunct treatment with medications.
Sir, what is the age from which we can use it?
Okay, that's again a nice question. There is for acute effects, there is no problem. Like people, they have used it in children as young as 4-5 years also. But the main mechanism of action of any tDCS or TMS or any neuromodulation for that matter is neuroplasticity. It alters or strengthens or weakens the connectivity among different brain regions. Now, in children, the main question that we need to be, or main understanding that we don't have as of now is that it is the developing brain. There is a plasticity, there is a constant change that is happening, and there is a trajectory of development that is going to happen. And the tDCS or any of these neuromodulation, how they are going to alter these trajectories, we don't have any idea as of now. Whatever the studies we have done, it has been only for acute. The maximum with with the ADHD that has been tried is the follow-up is for only 1 month or maybe 6 weeks, 3 months. That was the only study. So rather than beyond that, we have not studied. So long term, will it going to have any effect? It's difficult to say. Short term, there is no reason for us to believe that it will be unsafe.
Any other questions?
Yes.
I am Dr. Sreeraj from Chennai. Some add-on benefits of tDCS is not only medical or therapeutic. Some add-on benefits like it has been proven very useful to improve memory, focus and attention concentration, especially for those appearing for competitive exams. It is very good. It has been proven very effective. It improves the memory. And more than that, they have conducted a study in US Vita pilots. tDCS was used in US Vita pilots, and they tested the observation and the attention capacity, and it has been proven very much. So it can be used as an add-on, and not only for medical purposes and for general.
Yeah.
And mainly, especially learning new language.
Yeah, it is
very useful.
It is a major issue, what I would say as a question of neuroethics. How much neuro enhancement has to be done without training. So there's an emerging, it's not an emerging, let us say it's the last for 1 to 2 decades we have been discussing this, that should we use these neurotechnologies. There are a lot of, if you go to Google or even YouTube, you will be able to do-it-yourself tDCS which are available. Okay, and so you can get all the instruments and do it yourself and put it to improve your memory, do it before exams. All those things are there. How much they are ethical, those are the things that are being discussed. I am still a little skeptical, so I'm just putting that point across. And the other issue is also about homeostatic plasticity. What we definitely know is in the dysplastic brain, it enhances the plasticity. In a brain which is already plastic, and we are going to use it for repeated sessions for multiple period of time. So how it is going to have an impact? Because brain will respond back, try to defend itself from any external stimulants that will be coming in. It could be alcohol, it could be any drugs. Brain will always try to protect itself by different mechanisms, and that mechanisms will always be opposite to what you are intending to do. Right? And the same thing might happen here. So those are all the theoretical questions that we have to see, and there are issues. Single sessions is where it has been definitely seen that in individuals it will help. Gamers use it, not just the pilots. The gamers, when they in the competitive games, so when they are doing the gaming, they use this kind of devices, put it on the head and then play the game. But yeah, I would definitely not recommend from my side to go for any such things, because both theoretically as well as ethically as well as safety-wise, I have my own doubts regarding that.
Thank you. I know there will be a lot of questions because of the session. Next session there will be sir will be around, so please ask him in person. So he'll readily be clearing your doubts. Thank you so much, sir, for this session, and thank you for the organizing committee giving this opportunity. Yeah, there are few features. Thank you for the audience for the patient listening, and Dr. Varsity volunteering. Thank you so much.